So this is a research discussion, a roundtable. I just have a few slides to help guide the discussion. I've divided up the topics into four, and they're on the two slides, this slide and this slide. So topic number one is really focused around epidemiology and the clinical course of the disease. If we're going to make a pitch to any pharma to use their drug for superficial siderosis, we have to start with how many patients are there? Is it a rare disease? They need to figure out how many patients they're going to be selling to. Like, this is a really critical point. And just having the experience of, well, I only have 300 patients and there's 300 million people in the US, so it's 1 in a million. I don't think that's good enough. I think we really need a better way to measure this, either through medical record reviews. You guys have done a study with random sampling of MRIs. We could try to reproduce that. But I think the first thing we need to do is just figure out what the prevalence of this condition is. And maybe some ideas. Do you guys have, Dr. Waring, I know you've been thinking a lot about this. What is the best way to do this? How do we come up with a correct number?
Yeah, thanks, Mike. I mean, I totally agree. This is a critical point, and it's the starting point for understanding any disease, isn't it? How common is it? So if we're going to be methodologically as rigorous as we can, you want an unbiased population-based estimate. And the way we thought about it was, well, the UK Biobank has sampled 500,000 people randomly throughout the UK. And we thought, well, let's have a look at the scans that were done and see how common it is radiologically. So I think that is a reasonable starting point. But then we need estimates in other populations, and we've got to distinguish between the radiology and the clinical phenotype, because we could argue that what we've looked at is the potential future burden of the clinical disease, because we pick people up at the earliest stage.
And did those people that you picked up, did they have a neurology visit where they complained about hearing or something?
Yeah, well, unfortunately, our access to the data ran out. The UK Biobank have got very strict now about data access. And basically, they pulled the plug on our access. So we weren't able to look at whether they'd had a hearing test. But what I can say, Natalia may wish to comment, because she looked at all the scans, 12,000 scans, I think she looked at. We found they all involved the superior cerebellar vermis without exception. And there was only one, I think, when there was a little bit more widespread involvement.
I think, yeah, one, two. I can't remember now for 100%, but yes, 1 or 2 would have cerebellar folia as well. And one case had also additional supratentorial involvement, but I think there was a separate, as in there was only 3 areas, so supratentorial and infratentorially, vermis and folia.
Isn't there a lot more data, though, in that there's cortical superficial siderosis? I think they either screened a Dutch or a Danish population of people over 65, and they found like 4% of people had some focal siderosis. Isn't that more likely, or how is it that you found? Were you looking for that as well, like focal siderosis, or just cerebellar?
No, but I would have marked it as when I was screening through the scans, I would have flagged the other ones.
You looked at top to bottom.
Exactly, yeah. So, but because the population sample was younger than in which cortical is prevalent, so I think that's why we missed it. And also, my understanding is that UK Biobank recruited healthy, or at least deemed healthy participants at the baseline assessments. I think then they opened up to those who wanted to participate or shared the GP records through the National Health Service.
Yeah, just to come back to the cortical siderosis, Michael, that is a bit more common, I think. I don't think it's quite 4%. There was the Rotterdam study. There have been some other population-based MRI studies. So the cortical siderosis in older populations probably is a bit more common. But your question was, what do we do next, wasn't it, to find out the prevalence of this condition? So I don't know whether there are any existing US population studies. Obviously, there are famous studies like the Framingham study. There are epidemiology studies that are happening.
With MRIs. And they have to have a susceptibility weighted image.
The Framingham did MRIs.
Did they?
Because they've with quite a lot of studies.
With the iron scan, you think? Maybe.
They would have done SWI because they've reported on microbleeds in the Framingham study, which Framingham is a village around here, isn't it?
It is. It's just west of Boston.
So
maybe we
know people. Is it Romero? Professor Romero is the imaging lead for the Framingham study.
I don't know, but we can look into that.
Yeah.
Okay, isn't that an older population?
Yeah, and it's quite an old study, isn't it?
Because the Framingham has been running for at least 40 to 50 years now.
Okay, so a random sampling. What about a neurological clinic sampling? I mean, it's obviously biased, but maybe there are patients who've been admitted to the stroke team or something like that have superficial siderosis as well. Should we?
So Natalia, you looked at this. We did a systematic review of studies, and we did find that the prevalence was higher in hospital cohorts, just as you'd expect. And we did a meta-analysis, didn't we? A simple one, a pooled analysis, which found the pooled prevalence was something like 40 per 100,000. 40. And our own study was 48, I think it was, and some of the others were a bit higher or a bit lower. So I think you're right. There are studies out there, though, so we've kind of looked at some of those. They're radiology ones. But maybe it needs another truly systematic review of what exists in terms of databases with MRI and clinical.
There was also so there was also a group from Germany. They published a review of their imaging data. I think they had 99,000 scans that they looked at, and very similar radiological prevalence to ours. Yeah. So perhaps even just to look at the entire SWIs of Mass General, see how many there would be. I don't know how accessible it is to your team.
I mean, when you went through the images and you saw a cerebellar finding, did the radiologist not pick it up? Because it would be a lot easier to screen our medical record system for the phrase superficial siderosis rather than looking at literally, I mean, did you literally look at 10, 12,000 MRIs?
So coming back to the study by Germany, I think exactly they looked by searching the word in the clinical report, in the radiological reports of all of the imaging of the patients that they did, of the cases. Regarding UK biobank data, there is no associated diagnosis attached to the imaging. So it could be anything. So you just go to see what you find. So I physically... No.
So I think they might have missed it. It was pretty subtle, actually, and we had to get it all cross-checked with a neuroradiologist.
Several.
But you did look at them. Well, it was during COVID, I think, wasn't it?
Exactly. So
much else to do.
Exactly. So with my PhD being on hold because of COVID and all the recruitment and all the facilities shut down, and also patients were deemed high risk, and also over 65 patients were also deemed high risk. And
we did this because the primary project couldn't be done during COVID.
Exactly.
So we thought, what else can we do? And we thought, well, there's all these scans.
Exactly. So I did this. I mean, in a way, it was a blessing. Yes. So I looked at all of that data. Actually, it wasn't too long. I just had a very powerful machine and a high resolution screen. So
a year, wasn't it, Natalia?
Something like that. But yes, on and off, and then you're doing other stuff as well. So yes, but I mean, I would do that in the evenings, when it's dark, so it's easier to see it. And then during the daytime, you go to do your clinics or whatever you have to do, So it's fine. Yeah, I mean, it worked really well. It was just, I think I wouldn't have done it.
You can all read that paper in the Journal of Neurology, 2023, was it, Natalia? 24?
The UK Biobank.
Yeah.
25, January.
Oh, 25. Okay,
yeah.
It's very recent.
And then there's the issue of MRI versus a clinical diagnosis, because would anybody here treat those 6 cases with the little cerebellar siderosis, or would you only treat a patient who has hearing loss?
In my experience, having reviewed our patient data as well, and also having reviewed their radiological, and past radiological, so preceding the diagnostic radiological findings, a lot of them would have had these exact superior vermis cerebellum involvement without the symptoms. So, and they would have had a scans for something else completely asymptomatic. So in my opinion, I think this is radiological preclinical diagnosis.
So I would look carefully at whether they've got hearing or balance problems, because they may not have recognized the problem. So you've got to ask and you've got to measure these things. But I think usually I wouldn't treat unless I saw some evidence of something that's actually having an impact on their function.
Okay. So in the multiple sclerosis world, we used to do it that way, where we didn't treat until they had a clinical finding. But now the MRIs are so clearly obvious that we know they're going to eventually develop clinical findings, so we treat them before that because we want to preserve brain tissue. Maybe that's the future of superficial siderosis as well.
I'm just thinking, sorry, just very quickly on that. We probably ought to go back to the biobank and say, can we actually get the data? Can we find out what happened to these people? Because, I mean, it would be money. I don't know how much it costs, but we ought to really do that.
That's exactly what I was going to suggest. Taking those patients that were asymptomatic, that had radiological findings, and see how they're doing now to see if there is any evidence of progression of disease. And then you might have a point, yes, we need to treat this patient preventatively.
Does it stop? And does some people just limit it to the vermis and it never progresses because they have good homeostasis of the iron?
But I think we should first work with our own imaging. We have so much imaging just to see the progress and in terms of radiological progress, and also how that correlates with the clinical picture. And this is what on my to-do list, because we have come up with the anatomical rating scale. I've included some of the, the diagrams in my talk yesterday with the little, like I also, again, COVID time, so I had to improvise, do a bit of artwork in this. So, and it came with very actually high agreeability score. You know what I mean? Anyway, so
we may be moving on to Michael's next topic, which is
yeah.
I don't know if we want to close the prevalence questions before we.
I just had one question for you guys. So I don't know how the UK Biobank works, but don't you have an ethical obligation to tell patients when you find something like that?
So the study itself has a governance plan and an ethical plan for incidental findings. As the person accessing the data, we don't have responsibility for that.
No, but I did contact them to let them know that we have significant findings identified. Whether they wanted further information or not, they said they didn't. Or whatever it is, they would be dealing with it themselves. Needed from us, yes. So yeah, no, the UK Biobank, yes. So whatever was identified incidentally, my understanding is that they would have dealt with it already. Yeah.
And one thing is they've got another 90,000 MRI scans now, I believe. I think they're up to 100,000. So with the resources, the funding or the staff or whatever, or to access, we could look at another 90,000 and see if...
Only 9 years.
No, so I think we were also discussing getting it automated, getting automated analysis to rerun. And also my understanding is that they are recruiting out to do interval imaging data, collect interval imaging data. Because they've started doing that on the clinical data, so they've started doing it on the imaging as well, as I understand it. I mean, I may be wrong.
They didn't do QSM, did they? You don't know the answer, Susanna. For UK Biobank?
I don't think so.
Do you have some sort of automated? Do you have an automated system that you could take their 90,000 scans and just see if it has an SWI signal in the cerebellum and then report back, so that she doesn't spend 9 years doing this?
Locked in a dark room.
I know that our translational sciences team have worked with the UK Biobank, and it's not unrelated to the brain, it's to do with liver studies, but if we've already got access, I'm sure there would be a way. I just need to speak to the relevant people internally up high to see if that's even possible, but I don't see I don't see why it wouldn't be possible.
It is actually fairly quick to do a screen of the SWI to see is there anything going on. The trouble is I don't know that we're going to have an AI algorithm that can pick up the subtle cerebellar involvement that we kind of trust it at this point, that we wouldn't be missing any. I don't know, Susanna, but have we got something that's really got that? We want sensitivity, don't we, here, so we don't miss any cases. I think we're still going to have to verify it with a human, perhaps. I don't know, but
because that would be the perfect setting, is to do a dry run instead of treating them immediately. Come back and do it again, the QSM, do it again in a year and see if there's any movement, any changes, and then yes, that will be somebody that I will treat eventually if there's any changes.
And of course, that wouldn't be terribly expensive for resources, would it? I agree. I totally agree. Because say we found 5 or 6 cases, and then we find another, I don't know, 9 times that, another. So you're up to about 50 people. Then you could do a cohort study where you just apply to see what happens to them.
What about the clinical cases? Is the only way to do this to take the number of cases in one center and then just divide by the general population of that area? I mean, how is there? You guys have a nationalized system. We don't. So can you do this in the UK?
What we could do in the UK is the Association of British Neurologists has they call it the radar system, where you ask for all cases of a disease to be notified throughout the UK. So that's one way we could cross-check that we're getting a similar estimate to what we think is the prevalence from that method. And we could do the same kind of calculation you've done, Michael. So we have 130 people that we've seen. And if we divide that by the UK population of whatever it is, 60 million, then it's going to come out fairly similar to what you've got, perhaps, isn't it? But
you have 1 in 5,000. We have about 1 in a million.
But we could triangulate
per million,
the
we have 1.
British neurologists. Natalia may want to add something.
Yes, I just wanted to ask actually Rory and Kyle, because with the SSRA you have patient registry, so I assume that you can actually look at the USA based patients and then, yeah, or at least even just to say, please, register as, without putting their name or anything, just kind of a flag it as a, do you have like a yes or no question? Yeah.
How many patients do you have in the US? Okay.
Did you analyze them? Did you analyze them by region to see if there's any variation in the regional incidence or prevalence?
We have 1 in Russia, we have 2 in Poland, we have 3 in Finland, things like that. So it's not a large number globally. The majority of our patients that are registered are UK and US. Australia, we kind of lump the disease within Australia.
So whether we could collaborate and include that data as well, and also with the SSRA UK, we can. Yeah. Yeah.
But what you need is that you need an unbiased sample for each country, don't you? So the SSRA, you're going to get the maybe more informed or more engaged patients. I just wonder if there are countries that have got really good population-based data on disease. Australia is one, and the Nordic countries, so Denmark and Sweden, we haven't really got in touch.
Does Italy have a?
I don't believe so. Does it? It's not a. They've got a. It's a bit like the US, isn't it? It's insurance based, and
But that.
No, I think it's
Italy's universal. Okay.
absolutely.
Okay.
Spain is also.
But from your data and your groups, do we have any hint of whether the ethnic background plays a role?
Yeah, what a great question. I was going to ask that question too.
I was looking into that, and no, there isn't.
Well, ours are
Absolutely.
almost all white Caucasian.
Not necessarily. We have a few, I think, Indian background and a few others. So yeah.
Do you know the numbers? Mostly, isn't it? White British.
Well, mostly, but then I think they are representative of the population.
Yeah.
You know, like percent-wise.
Collecting demographics. Did you see any? Nothing local, and not everyone in one race. Okay. Do you want to talk about how you discovered the fibrillin 2 mutation in people who have certain leaks?
Yeah, so what we did, we first did a whole exome study where we just agnostic for what type of mutation we might find in patients with spontaneous leaks. That did not come up with anything. So then we looked at what we thought would be the most likely pathway, which is a pathway where extracellular matrix proteins are produced, and then we came up with these fibrillin 2 mutations.
From the same data set?
Same data set.
Who paid for that exome sequencing?
The NIH did.
You got an NIH grant?
Right. But that was, started 6-7 years ago.
For those of us maybe not so aware of the study, could you just tell us what that molecule does and how it? What?
Yeah, we've always thought that heritable connective tissue disorders were associated with spontaneous leaks, right? They're more common in people with Marfan syndrome, for example, or autosomal dominant polycystic kidney disease, Lewy-Dietz syndrome. But that's a very small portion of the general population with spontaneous leaks. So in order to increase our yield of finding something, we limited to patients who were younger than 45 when they had their leak. And, we excluded anybody who had even, a more or less trivial type of precipitating event.
This just reminds me of another question about the spontaneous leaks, which you've shown about half of them will develop siderosis over 5 or 10 years, I think it was. My observation of this is that they don't seem to have such a severe clinical syndrome when they do develop the siderosis as the ones that come to us having had trauma or neurosurgery. I just put that in because I think that's another natural history question. Do the ones with a spontaneous leak maybe behave a little bit differently to people who've had sort of a definite dural intervention?
Yeah, nobody really knows, right? We'll find out, I hope.
Ferritin molecules and its multimers, and see if there's any polymorphisms that make people get it more or less. And it's an easy thing. You have the blood sample, you can run a sequencing on it, and hopefully Foundation One or Tempus or anyone can, if they can help, a small.
Is there a PCR panel that you could do for that, or do you have to do the whole?
No, you have to, because you're looking at something that you don't know. You don't know what you don't know. Do you know what I'm saying? But if they can sequence the gene, the heavy and light chain gene of the ferritin molecule, it only needs a blood test. But then we need funding, and we need the test and Tempus or Foundation One or Caris or any of.
Total, do you think it's going to be a bunch, and we should really just sequence the whole thing?
I think it's good to sequence the whole thing.
Okay.
Because we don't know hotspots to do just a particular set.
$1,000 a patient.
Yeah. We'll see if they're interested in doing this on small sample and see if we can find anything.
What about that Ian guy? Ian in the UK, could he help us out with the sequencing?
Ian Galea, yeah, I think he's still interested in haptoglobin polymorphisms, which is the scavenging system, isn't it, in the spinal fluid. So we can certainly reach out to him and see what's happening.
If he's doing that, he can add.
Yeah, does he sequence in his lab, or does he need funding for the sequencing?
He's got a website, it's called the Hatch Consortium, HATCH. So I'd have to go and have a look on his website and see where they got to. Can I just clarify the biology here then? So the ferritin, there are polymorphisms, which means you've got either more heavy chains or light chains. And
You can get polymorphism in both.
Do they?
The light chain genes and the heavy chain genes.
And that affects the efficiency of
That affects which part, that will affect which part of what are you trying to do with the iron molecule. The heavy chains will just stop it at the F2. The light chains will convert it to the long-term F3 and sequester it. So it will convert the active molecule from the F2, the reactive one. Heavy chains will control that part. The light chain will go ahead and sequester it for the long term.
Have we got population data on how likely variants are in this, though? Because that could be quite an interesting basis of why some people are more susceptible. Do we know in the population the degree of variability?
I have not looked it up.
Are they SNPs that we could do for $100, or does it really?
I don't know exactly. That's why I'm saying the idea of sequencing the whole thing is because we don't know for superficial siderosis what is the makeup of these things.
I was trying to think of a cost-efficient way to.
I understand. I completely understand.
I mean, we could certainly try and bank blood on everyone who we see in the clinic, and then you store the blood, and then we can try and think.
Yeah, we really should be doing that anyway.
US, you have the Million Veterans program, and you have All of Us. I was the PI on the All of Us part in Louisiana, with where we have a lot of samples, and you can apply to get into the biobank and get those samples. But that if you know which one has superficial siderosis or not, you can get those samples, apply for it, and they will share it with you.
Same in the UK, actually, the 100,000 Genomes Project, or whatever it's called now, Genomics England. There are data that we could access, I guess, to look at this.
And not to reveal any private information, but I do have a lot of military members with superficial siderosis jumping out of helicopters and things like that. And so there may be some, that might be an opportunity then. Also with funding, I don't know if Department of Defense, I heard their budget's being slashed, but maybe in a couple years or something. Okay, should we move to outcomes? These people who are stable versus people who seem to have rapid outcomes. Is this I don't even know. I mean, do people think that there really are different natural histories? Or is it basically just a matter of time and how old you are when you have it and how well you compensate? Should we try to track this?
And I work on, I'm just coming from my background, I work on rare T-cell lymphomas. And what we try to do in that area is get a data bank or a data set, a huge data set. And what we try to do is also, that's what I do usually for my research, is risk scoring to see actually who does well with chemotherapy, who doesn't do badly, what the outcome of this one versus that one, because that way you risk stratify the patients. And that will eventually help you guys in choosing who's going to go on this drug. Is a high risk, who's going to, why should you intervene early and if they have the high risk characteristics. So that's something, if you have the database, I would definitely look at risk scoring.
But I guess my question is, let's say you have two patients, they're both 55 years old, they both have a spontaneous CSF leak, and they both have a moderate amount of hemosiderin deposits. Are they going to have the same clinical course?
Be the amount of bleeding that they have, maybe that can be measured or somehow gauged in the amount of xanthochromia that they have in the CSF if they have a study in the CSF. So if they have a lot of xanthochromia, maybe that's a huge bleed from the beginning, and that might go to different clinical pathways.
Sorry, I've got.
Yeah, so just maybe I'm revealing too much, but just to say we are actually looking at the CSF data. I've collected most of it, just updating the last 20 patients. So we're going to look at the red cell count, ferritin, so the burden of the CSF markers, and then try to correlate, at least with the only quantifiable assessment from the audiovestibular side is pure tone audiometry, because you can calculate and get a figure. But I don't think it would be a highly representative of clinical picture of a patient just by having this pure tone audiometry measure. But at least that's a start, and I'm actually brainstorming every day as I come across other things, just to see how and what other ways to quantify audiovestibular clinical findings, and then attempt to correlate with the CSF and the imaging, because we now have the imaging scoring. Hopefully we will have the CSF scoring and come up with the clinical scoring.
So the answer to your question, Michael, is if two people are, they've got spontaneous leaks, they've got moderate burden of siderosis, are they going to be exactly the same? I think we've probably touched on it a little bit, haven't we, already, that there are likely to be susceptibility factors that might affect the progression, so the efficiency of the sort of blood hemoglobin scavenging systems might be one of the factors. I think more important in siderosis is the fact that the range of causes is quite heterogeneous. So somebody who's had a brachial plexus injury, for example, compared to somebody who's had a spinal tumour that might even be a malignant tumour, compared to somebody who's had a benign pilocytic astrocytoma of the cerebellum, compared to somebody who's fallen down a mountain, compared to somebody, they're all different injuries and different triggering factors, and I suspect they are going to behave differently. And it's complicated, of course, by the deficit that comes from the tumour as well, if they've had a tumour. So I always find it very difficult when somebody's got cerebellar problems and they've got siderosis and they've had a tumour resected, which is the original injury. So I think the short answer to your question is probably we need to be stratifying according to the cause, maybe try and obviously not look at everyone individually, but group them into people who've had trauma, people who've had neurosurgery, people who've had a tumour. Is there any evidence they might do differently as groups? I don't know. These are just thoughts, really. But
what they might be doing badly because of what the underlying issue is. So you don't expect somebody who has a high grade astrocytoma just because he has to do better, because they're going to do worse because of the astrocytoma rather than anything else. So it's a good idea to stratify them, definitely.
And for a trial, that could be really important as well.
Okay, we get to the MRI research. This is the toughest thing. Alex and I tried to do what you're doing with the scoring system. And then we sent out, 4 or 5 MRIs to 4 people. We trained them how to score, and then we all got different numbers. And then what we did was we got together and we said, okay, let's all go through it together and why we chose what we chose. And then we said, okay, now we have a better sense of how this is done. Let's repeat it. And we got a little closer to homogeneity, but still there were differences. It's just 2 people looking at the exact same thing and making a different determination.
Was this using our scale, Michael, the quasars one that we put together? Or?
It was close. We had vermis, rest of the cerebellum, temporal lobes, cortex, spinal cord, stuff, something like that.
So I think that really beckons this, or is that the right word? We ought to publish this ASAP then, because it was me and a fellow neuroradiologist. She's now an attending neuroradiologist, and we had really, really high intra and inter-rater agreement scores. So the plan was to introduce the rating scale and clinical data with some interval imaging scores, but maybe we'll just introduce the rating scale for everybody out there and then publish a second paper then.
I'm interested to know. Well, I don't. I actually think it. No, I think this is really interesting that you got less agreement. I think this was just a really pragmatic way of just trying to somehow quantify the extent of the siderosis. It's very crude, very basic, but I think it was in the absence of better ways to do things. We thought it was a reasonable thing to look at. I don't think it's going to be very sensitive to change, but I think it's something that maybe we should do a bit more validation, and we could work together to see.
Yeah, you send us yours and we'll score them, and then we'll send you ours and you score them and see.
I honestly don't think it's the answer to quantify siderosis. It was just a pragmatic kind of
an objective measure.
Didn't you present in your presentation? Who did your AI quantitation?
Okay, so the way we did that, and you're going to laugh at me because it's so crude, is we just used Osirix, that software, to create a region of interest and outlined all of the brain. And then we just asked a very simple question. We said, how much black is there relative to the whitest white? And then we did that longitudinally. So we said, okay, here's brain MRI number 1 before drug, here's brain MRI number 2 and 3 after drug. And we saw the numbers go down, the amount of black goes down. But is that even a reliable way to do this?
I would say no, because you've got other compounds and stuff going on in the brain. So that blackness could be some sort of calcification or something other than iron. So you don't really know. And so you need to basically determine what is what. But you could validate the quasar scale and make it automated, so that after however many rounds and agreed scores, you've got the quasar scales, and then use that against some other quantification method to say someone's got superficial siderosis.
I also think, Michael, there are other variables that could influence the blackness that you're measuring. Obviously, the orientation of the scan. You need something that's rotationally invariant, really, because we know this from all the MS trials, don't we? The diffusion tensor and stuff. You need, when you look at quantitative MRI, it needs to be something that doesn't change with brain position. I think it's it's interesting to look at it, and you're probably getting some signals there might be something going on, but I think you get some rigorous kind of physics person appraising it. They're going to say, well, it might not just be rigorous enough to really know what's changing. And I think you're right. It's non-specific, isn't it? The blackness, it's from magnetic susceptibility.
We're quantifying an artifact with the amount of black. Exactly, it's a blooming artifact, and we're just quantifying how much black, even though it's the same patient and the same scanner. So I don't know that it's a calcification issue, but maybe and we try to do a whole volume of the brain, but we're not even just, we're there's variability in terms of where we cut off the surface, where the skull is versus where the meninges. It's a very crude measure that we try.
And where does the hemosiderin end? Because you can't see the outside of it necessarily, where it borders other tissues. I think you're absolutely right. It's a magnetic susceptibility artifact, isn't it?
I'm just wondering if there is any way that, for example, you can put these things into a software, and the software can look into the pixels and then determine the gradient of intensity of the signal. For example, image have some features that can do that. So, but I'm not an expert on this area. So, what are your thoughts on using this kind of software?
Okay, can we take scans that have already been done and then process them somehow?
If they all had the same scanning protocol, then but it
These
would
are clinical scans.
Yeah, it would be very difficult. And another way of quantifying, it's not as reliable, but there's R2 star, but that takes a summation of everything. It doesn't tell you what the iron would be within the pixel. So it is a easier way of doing it, but it's not going to tell you the amount of iron. But if you've managed to, say, take SWI and you've got a similar sequence, and say that I don't know, you have a range of what the parameters should be at, you could possibly look at existing clinical scans. But again, you'd need to make sure that it's same scanner, and I don't know what that.
Yeah, these are all different scanners, but I have about 300 cases and I've kept all of their CDs. But these are cases that that includes scans from 2005 all the way to 2025. 20 years of data, but on different scanners, different protocols, if there's some way to standardize that. And because when I look at the amount of black, it seems like after 10 years, the amount of black really goes down. So if there's a way that you could just look at that and say, oh, okay, then this is a better way to quantify it, because my eyes are telling me that there's a lot less black after 10 years. Isn't there a way to quantify that?
Say that scanners have improved significantly over the last few years. So what you're saying from back then, if you're saying that it's reduced now, then I would say that it definitely has reduced, because scanners are of better quality. There's more understanding around the field strength and the parameters. So I'd say that basically there is some sort of reduction. But yeah.
Have you looked blinded to what's going on clinically, Michael?
No, because not blinded.
I think biases are really,
Yeah.
you just can't get rid of those. It's very difficult because we see what we want to see, don't we, sometimes?
Yeah, and I have a really funny story to tell you. I put in a scan into ChatGPT, and I put in 2 scans, and I accidentally put in the same 2 pictures. And ChatGPT said, it looks like one of the scans is lighter than the other. And I said, oh, that's really interesting. And then I realized the mistake, and I said, where do you see the difference? And then ChatGPT said, well, when we do it objectively, there's no difference, but it just looks different. I was like, how does ChatGPT look at something different? It's crazy.
You need to be careful with ChatGPT, because it hallucinates, number one. It's true. It's a technical word. It's called AI hallucination. Second thing is trained to be polite, which actually misguides you, because many times you ask it a question on an article, and I did it. And I said, where do you come up with this information? Please cite the page and the paragraph. And it did cite a page and went to the article. There's no such thing. I said, you're lying here. Why did you say this? Oh, I'm sorry. And by the way, it's very, very polite. I'm sorry that I didn't get to that point, or I didn't saying that I didn't present the exact data. Why? Well, I was trying to help. This is the problem with ChatGPT, is sometimes it's trained too much to be supposedly emotionally competent, that actually comes up with stuff just not to say, no, you cannot do it.
The skeptical version of ChatGPT.
Yes, like the Grok.
Grok. Yeah, no, we're not using Grok, definitely. No.
Okay.
He knows what I'm talking
Just to say, SWI, presumably that's what you get most of the time these days now, because we don't really use T2 star anymore.
Yeah. And then gradient echo back in 10 years ago.
As I understand it, you do get quantitative information. You get a phase map, you get an amplitude map, and maybe we should go back to the physicist to see if there is any way of deriving some sort of quantitative.
That's what that's
SWI,
my sense,
rather than a dedicated QSM.
Yeah,
because QSM, you need to get different echo times, don't you, to quantify it? But there might be information within the SWI.
I'm sure that they can actually standardize things according to a baseline within the same, a control within the same scan, and then standardize the content based on another area. Yes, yeah.
That's what I was thinking.
But again, I agree with you. I think a physicist should be sitting there.
Well, we maybe need an imaging working group, try and get some real imaging experts together, because it's quite technical stuff, this, isn't it? And obviously, Perspectum is a good source of expertise in quantifying the iron. I don't know if I might move on to one other thing, Michael, that I think we probably can quantify reliably, and that is volume, tissue volume. For example, cerebellar volume, which you would imagine the volume of the tissue is highly likely to be functionally relevant to how the person is with balance and stuff like that. And also the area of the spinal cord, and even maybe cortical volume. And as I understand it, it's pretty robust now, deriving volumes from a T1 volumetric image. even if there's a bit of scanner variation.
Yeah.
It's not perfect, and it doesn't have the artifact from the magnetic susceptibility, which is the wonderful thing. You can see the tissue not affected by the iron.
Are there public tools for that? I think there are, right?
They're really good cerebellar volume tools, which they use for conditions like Friedreich's ataxia and spinocerebellar degeneration. So this is an area that I just haven't had the bandwidth really to look into, but I think
That could be the best way to quantify whether we're preserving brain tissue.
exactly.
And it's really sensitive.
And in MS, we know this, don't we? We know that you can measure volume from the statin trials and all the interferon trials and everything.
Maybe that's the best way to do this. Forget the iron scans. Just look at brain tissue.
Well, I think we should do both. I think this program has started, and I think it's really important to continue that iron measurement. But I would really like some work to be done on the volume quantification.
Yeah.
And we could do some quite early work, just seeing does it relate to function, based, just a cross-sectional study.
Before our break, can we get to the CSF biomarkers? Do you think your patients would do a lumbar puncture once a year to quantify CSF biomarkers, ferritin or whatever? Is that a lot to ask?
I think we have to ask the patients. We definitely have to ask the patients.
Would you want to do this?
Personally, well, a very, very long time ago when I was looking to do a biomaterials PhD, a great neurosurgeon suggested forming a biomaterial loaded with deferoprone and lumbar puncture it into the spine every 6 months, and I said no. But personally, to actually have a lumbar puncture, just because of I'm curious about the data, I guess I could agree to one every year if it's done correctly and it's all fine.
Of course it's done correctly. We're all trained neurologists.
My last one didn't have the right vial taken, so.
A yearly or something like that, twice yearly maybe. I don't know.
So, just to introduce myself, I'm Pamela. I'm a CSF lead patient and a physician. So I have a ventral dural tear, and I'm at, higher risk of superficial siderosis as compared to other lead patients. In my personal opinion, as a patient, I would be opposed to doing the lumbar puncture if possible. I wanted to ask if there was more non-invasive measures to measure, superficial siderosis, because, as we may know, iatrogenic causes of CSF leaks can include things like lumbar punctures, and it also depends on the type of needles used. Cutting needles, and contrary to popular belief, I've understood, from the medical literature and also patient experience, there are patients who do not heal from a CSF leak caused by a lumbar puncture. In fact, I come from Singapore. I'm based in the US now, and I am aware of patients silently suffering due to an incorrectly done lumbar puncture. Yep. And they have no access of care because, first of all, the physicians there do not recognize that CSF leaks do not spontaneously resolve. After 2 patches, they have a so-called normal imaging scan, and they are basically denied treatment. And this is not uncommon. Yeah, so that's my take.
Thanks. I just wanted to add another opinion to that from someone living with superficial siderosis who also had a CSF leak not caused by lumbar puncture. I regularly have lumbar punctures. I was having every year at one point just to monitor my CSF ferritin levels, and to see that going down over the years since I first had the ferritin measured when the sample was sent to Queen Square, and to see the significance in the ferritin levels drop, it gives me hope that the surgery itself has worked, because I think that was for me that was the predominant factor in reducing the CSF ferritin. But I still have a hope that the deferoprone is helping to reduce those levels as well. And the combination of the two, for me, in my opinion, is that's done. And to see all the other levels baseline and stabilized as well. Specifically the protein and the blood counts in the CSF as well go back to sort of basically normal levels, other than the ferritin, which is still marginally raised, but it's borderline normal now. It's I think your baseline levels for your CSF ferritin is 0 to 12 at your UCL. And mine's now averaging about 24 from gone down from originally when it was measured was 189, so it's come right down. And for me, that's it's great to see, and I'm more than happy to have the lumbar punctures as long as they're done correctly. And it is nice to have it done under fluoroscopy guidance because it hurts less. But other than that, yeah, I'm more than happy as a patient to have that done.
I was just going to add, you talk about IR guide. I think that is probably a better experience for the patient, isn't it? If you have it interventionist led, so it definitely goes in the right place first time and so on. I was just going to say, we've got data from Alzheimer's disease cohorts of people who generally the acceptability of lumbar punctures, as long as it's for an important. Sorry,
Is it on?
oh, sorry. I was just going to say, from other neurological diseases like people with Alzheimer's disease, for example, I think lumbar puncture has traditionally been a really key biomarker of whether you've got Alzheimer's disease or not for trials. And in the dementia service in my hospital, they have clinics just for lumbar punctures where they do lots of them, and it's routine and it's broadly acceptable to patients as long as they know it's being done for a good reason and it's going to help their care. But I totally take on board there is a small risk of leaks from a lumbar puncture, and I think we need to understand from the patients what they think.
Well, look, also, I think it's important, what is the purpose of the lumbar puncture and the biomarker. So if you're in that situation where you have a leak that has not caused superficial siderosis yet, but we know that after 15 years, there's a 50% chance of having developed superficial siderosis, most patients will vote for, having their leak repaired, even if they have no symptoms from the leak anymore. But I think for those patients who, for whatever reason, do not want to have their leak repaired, then maybe for those individuals, which I think is going to be a really small proportion, it might be useful to do a yearly lumbar puncture. Everybody gets a leak after a lumbar puncture. If you do an MRI within 24 hours, 95% of people will have, radiographic evidence of a leak.
And what's your experience of the incidence of leaks that don't settle down and that actually cause problems along the lines that we just heard from Pamela?
Well, we don't have those data, right? Because we only see people who still have leaks. I think quite a few leaks will resolve spontaneously within, minutes, hours, days, weeks. We generally don't see those people. But certainly for a ventral leak, if that's been around for more than a few weeks, it will not resolve spontaneously.
Can you get a ventral leak from an LP? You go too far or something?
You can, but I'm more talking about spontaneous leaks. But certainly if you do a lumbar puncture through and through, right, then, which is pretty common still that people do that, yeah.
I might just add the data. I don't know how much CSF data other cohorts have got, but Natalia is going to be looking at, it's about 60 people with lumbar puncture data, isn't it? So we can look at actually what is it telling us and what does it correlate with? How does it change after repair? Those data might be quite useful to guide us as to whether it's something that should be part of monitoring. These are mostly done as just standard lumbar puncture by a resident. Yeah.
We only do them as under fluoro.
We only get fluoro covered for people with a BMI over 35 and a previous try at a blinded LP.
If it's a hospitalized patient.
No, this is outpatient, right? Yeah. Insurance won't pay for it otherwise. I don't know how you're getting that done in Louisiana. Oh, with the VA. Okay. And then just last point is that we still have some patients getting myelograms. That's an opportune time to capture some CSF where they're getting a procedure done for a legitimate purpose to find the leak. And since they're there anyway, then we can sample some CSF, but it's not going to be longitudinal. We might be able to capture a CSF marker at that moment, but to then ask them to come back. Yeah, Reese.
My understanding is that, and I think, David, we discussed that with Dr. Cowley, is that when it's dynamic, I think it's a lot more challenging and technically challenging to take the CSF because it's really quick. So they need to inject. And also this is reversed. Yeah.
But you don't get CSF when you do that? You don't take a little to the lab?
We do, but the radiologist has been telling us it's quite difficult because they've got a lot to juggle with the positioning.
Okay.
But it can be done. I guess if you've got enough staff and you're organized.
It's not that difficult. I mean, they still have to start with their lumbar puncture, right? Then they'll remove a little of their CSF and then they'll inject the
yeah, we always do. We always get CSF when we do a myelogram, yeah. But they just started complaining that it was difficult. Yeah. The dynamic one is that there is positioning, isn't there? Depending on where you think the leak is, you put them in different positions. But it's totally, I think that should be standard practice, is you always try and get a CSF sample if you're doing a diagnostic myelogram.
But is there any value in that single time point? That initial time point? I mean, what are we going to measure at that time?
Well, we think it's really valuable to look at the ferritin because we think it's a biomarker of bleeding in the last few months. Red cells,
maybe,
and it could guide the selection of treatment. So if you've got a completely clean LP, you may say, well, actually, there hasn't been bleeding recently. Maybe we don't need to do an invasive treatment.
Do you ever check ferritin on your patients?
Not CSF. No, I don't even know if we tried to order it at one point and it wasn't even available. It was
that was the same with us.
Yeah, I don't know how you're getting it. Who's testing it in the UK?
Well, they do it in the lab at Queen Square because it's been developed as a tool for monitoring and diagnosing subarachnoid hemorrhages. And the lab has had a historical interest in subarachnoid hemorrhage, and they published one of the few papers on ferritin in subarachnoid. So I guess we're lucky that we have access to that.
Maybe we should save our samples for you guys.
Yeah, I mean, we can see if we've got the resource for the lab to check them.
Which actually is my question. Yeah, UCL.
UCL.
And for Mass General, do you have a specimen repository for all these patients?
We should. No, we have the capacity to do that. We just need to create the protocol and the standards, and we really should be doing that. Blood, spinal fluid, MRIs, data.
Siderosis biobank, that's what we need, isn't it?
A siderosis biobank.
And the thinking about the thinking about the ferritin is that it's a bit like HbA1c in diabetes, that it reflects the control of your blood sugar over the last few months. Ferritin might reflect how the bleeding has been over the last few months, but I don't know, we've got a lot of data to support that contention, but that's the thinking.
Okay, let's take a quick short break, and then we'll get to slide 2, which is all the different treatments. Then we'll convene in about 10 minutes. Left. And then one of the things that we've been talking about is after this meeting to continue our progress, maybe connecting by Zoom once or twice a year as we're making progress towards our projects, or as frequently as we need, but at least maybe an interval so that we can continue to make the progress. All right, there we are. Slides are coming up. This last half hour is really just about coming up with a treatment plan. I divided it into 2 parts, as I do in the clinic, which is part 1 is stop the bleed, and part 2 is the problem of iron toxicity. So maybe we can tackle stopping the bleed first. Woodward, do you think that we could draft a surgical protocol for either preventing, I don't think so, preventing superficial siderosis, or yes, or dealing with dural leaks, a standard protocol, do the myelogram first, et cetera, et cetera. Is there a protocol we could put in place?
Yeah, I think that'd be pretty straightforward. As a matter of fact, we've been saying for years that by fixing particularly a ventral leak, you will prevent the development of superficial siderosis. But of course, there are some people who, if they're not very symptomatic, choose just to go on with their daily life. In that case, I ask them to get a brain MRI every year. And then if they develop superficial siderosis, then most patients will be more inclined to have surgery to fix their leak. Because blood patches, fibrin glue injections will not fix a ventral leak if the leak has been there for more than a few weeks or months.
We've got a very simple protocol, Michael, that I'm sure you could expand on, Walter, which is we want to visualize the whole spine to look for any collections. We want to then, if there are collections, do a myelogram to find the actual definite pinpoint source of bleeding. And but we could definitely work as a team to come up with.
Yeah, so that's the other issue, right? So that we used to do that too, right? So you would do an MRI or a regular CT myelogram, see if there's a collection. But there's a number of people with CSF leaks who have developed superficial siderosis who will have a different type of leak that is not associated with an extradural collection, right? It's those people with a CSF venous fistula. So, if you have somebody with superficial siderosis and other MRI findings of intracranial hypotension, then I think you definitely need to look for a CSF venous fistula if there's no extradural collection. Well, you have to do one of these more sophisticated invasive testing, either a digital subtraction myelogram or I guess you guys do a dynamic CT myelogram. But those are invasive tests.
It's an opportunity to get CSF therapy.
That's right. Well, also for the ventral leaks, you need to do one of these invasive tests to localize the exact, level of the leak.
I think a really detailed consensus protocol on your approach to investigation would be really useful.
Yeah.
Do you think it's standardized, or is it one of those things where every patient is unique and you might do something different?
Oh, I think it's standardized, but I think, we've done a bad job educating other physicians, right? Just like that case I showed yesterday, somebody with dural ectasia, multiple diverticula, an MRI that clearly shows that there's not a ventral collection. That patient underwent, an invasive test looking for a ventral collection, rather than looking for a CSF venous fistula. And for a ventral collection, you put the patient prone. For a CSF venous fistula, you put them in the lateral decubitus position. So that makes a big difference.
I've got a really basic question about what evidence have we got for the outcomes of people who've had a dural repair, and what evidence have we got that it might help in the short term, medium term, or the long term? And is there an opportunity to pull data from all of our cohorts to try and look at this?
Yeah, I think we should do that. I mean, we've only had 2 patients where the superficial siderosis disappeared after a few years, but their burden initially was very minor. So I think that it's, a different type of situation. Everybody else who we followed with serial scans, there's not a single patient where we repaired their leak and their superficial siderosis has progressed.
So should there be an international registry of people who have surgical repair for their siderosis,
Yeah, that's an excellent idea.
Okay. All right. So we figured that part out. That was easy. Is there any role for these non-surgical approaches, fibrin glue, blood patches, anything there?
Look, if you have an acute leak, right, ventral leak, any type of leak, it can just spontaneously resolve. That can happen. You can do blood patches if it's early on, right, the first few weeks or months. You can do glue if it's been there for 2 or 3 months, but otherwise it's going to require surgery.
And can I ask a question about the different types of leaks? So pseudomeningocele in the posterior fossa is something we commonly see. Brachial plexus injury, another pretty common one. have you experienced of how they might respond differently to surgical repair?
Sure. Well, it's been my experience that the traumatic ones, right, like brachial plexus avulsion, are more difficult to repair because oftentimes there are multiple ones. The tear can be larger, right, than a spontaneous leak. So definitely that has a higher failure rate of surgery.
And the posterior pseudomeningocele, that's quite a common scenario.
Yeah, that also can, present a challenge if there's no good dura around it to suture your patch into. But we don't really know, right? There are not too many people who we follow with persistent pseudomeningoceles. We don't really know what their risk is of developing superficial siderosis in the future.
Yeah, I'm just trying to remember what kind of proportion of people we've seen who've had siderosis attributed to a pseudomeningocele. It's quite a high proportion, isn't it? 20% or something? Not sure. So it's something we need to learn.
I have one patient who had superficial siderosis that was thought to be from a posterior fossa pseudomeningocele after a Chiari decompression, but the actual reason was that there was a ventral leak that had caused brain sagging that they misinterpreted as a Chiari malformation.
Does the siderosis pattern differ if it's a posterior pseudomeningocele, because maybe there's more blood in one spot as opposed to a symmetric pattern from a more spinal lesion?
Yeah, I believe so, but I don't have that much experience with posterior fossa pseudomeningoceles that develop superficial siderosis.
I think they might look similar, You get the diffuse and it's firmest, but often the sylvian fissures and the interhemispheric fissure and the other areas.
I will have that answer for you soon, I hope.
Yeah. Oh.
I asked this question to David before. Do you think that it's worth, rather than, if possible, rather than craniectomy, to put the bone back in and do a craniotomy to prevent the risk of developing superficial siderosis? And the other question I was going to add to that is, if a patient's got a long-standing pseudomeningocele that's asymptomatic, is there any reason to have some sort of intervention if that pseudomeningocele is persisting for, say, X amount of years than you would expect it to, rather than collapsing on its own?
It feels to me, Reece, this is a question for a neurosurgeon, actually. Your first point was to do with whether you should leave an open craniectomy or whether the bone should be put back and sealed off. I think I'm going to defer to really neurosurgeons for this.
Well, it depends on what the craniotomy or craniectomy is done for, right? So if it's for, let's say, a microvascular decompression for trigeminal neuralgia, like when I was a resident in the 90s, they would generally not put the bone back. And a lot of patients had pretty severe postoperative headaches because their muscles would attach to the dura. And, dura is exceedingly painful. So now we always put the bone back or put a little metal plate on it. But if the craniotomy is done for a Chiari malformation, you would not put the bone back because the purpose of doing the surgery is to create more space. Well, I've treated some pseudomeningoceles that I could not repair with a shunt, but as you know, the failure rate is so high. So I always try not to place a shunt.
Question in the back.
Hello, my son Peter has just had a large dural defect repaired in Queen Square in London a few weeks ago. And the neurosurgeon, part of Prof. Waring's team, Mr. Seil, said he saw the tissue, he has superficial siderosis, and he saw the tissue next to it was quite siderotic. Is there a place for neurosurgeons, talking about collecting data, to give their visual findings in their post-op notes?
Well, we always try to put anything of value in our note. And that's something that's not uncommon, right? When you operate on somebody with superficial siderosis, that it's easily visible, right? The leptomeninges or the pia of the spinal cord can look, very brown. That's kind of a common finding. And as far as I can remember, we would always put that in our op note. Yeah, that would be very straightforward. Oh, you probably would. Yeah. And certainly if you do it, the traditional way where you open up the dura to repair the leak, right, rather than do it endoscopic where you would not remove any part of the dura, you could do that. I mean, I usually take some biopsies of the leptomeninges in somebody with superficial siderosis. But they just see, they say, oh yeah, this looks like superficial siderosis.
But you don't biopsy the brain tissue, you only biopsy the leptomeninges.
That's right.
So we can't see what we want to see there.
Yeah. No, they do special staining, but I wouldn't know the name of the special staining.
Interested in whether hemosiderin might generate inflammatory response and that sort of thing. We've got a lot of CSF and we don't see much evidence of inflammation, but if there were things that you thought we could test for to check for markers of microglial activation, or I don't know whether there are things you can measure in the CSF, but
certainly you can do telecom profiles, and in the tissue you can look for B cells or T cells that are infiltrating the tissue, or for example the microglia. Possibly you might need to start possibly in vitro to see if the exposure to iron will cause upregulation of the pathways of the microglia, becoming M2 pro-inflammatory and those things. So, but that needs to be maybe in vitro to see what is the effect of the iron on the cells.
it's a simple thing to measure some of these cytokines in the CSF we already have.
Yes. So if you could see a regulation of the cytokine, you can say, oh yes, there is a cytokine that is pro-inflammatory. Then you can say, oh yes, maybe there is some inflammation there. I mean,
if you see nothing, you may say, well, actually, it doesn't.
Exactly.
But is it available clinically? Is it collected in inflammatory markers in CSF?
Yes, you can send
You can
panel in the CSF.
Okay. No, I'm just looking at our data. I don't think we have that. We have taus, but not. No, we haven't. No.
You wouldn't do that. Diseases, would you normally look at interleukins or?
On a research basis.
Yeah.
Yeah. Yeah.
IL-6.
So if you have a lab that could do it, you might be able to.
Or we can check with our lab if they. Yeah. Okay. Great.
Let's jump into the last part here of iron toxicity and see if maybe we can come up with a strategy to pitch to a pharmaceutical company. We heard yesterday that there are other drugs in development that are iron chelators. We were told they do cross the blood-brain barrier to some degree, and that they have different affinities for reduced and oxidized iron, which could either supplement to ferroprone or replace it altogether. So we would need to pick our favorite drug, and we would need to design a trial, probably around safety first. David and I have talked about even doing that for deferoprone, just to create some science around deferoprone, to just do a safety study first and really capture 10 patients or 20 patients all taking deferoprone at the same schedule and demonstrate that what the rate of neutropenia or liver toxicity or anything else as really just a first step. And then the harder part is going to be to demonstrate that it has some efficacy. I like the idea of tissue damage as a T1 weighted, just a volume of cerebellum, or around this cervical medullary junction, maybe right there. We do that in MS. Or CSF ferritin, or some objective measure, maybe audiometry, some objective measure that we're making an impact. We could start with deferriprone, since we have access to that. A lot of people are on it. Or we could jump straight into a trial with a new pharma drug, where we might be able to get funding from pharma, rather than we've all been struggling to get any scraps from NHS or NIH funding for a deferriprone study. It's hard because the patent protection is already lost.
I think both simultaneously pursuing both at the same time is a good thing, because at least if you're doing the deferriprone now for safety, the deferriprone has been tested on hundreds of people for the transfusion-related eye. So I don't think anyone's going to jump on your bandwagon like, okay, we know what the safety is. However, if you want to design a specific safety for superficial siderosis, like checking specifically the hearing, is it going to get worse? So specifically for some neurological outcome that you're looking at, maybe that would be a good thing for deferriprone for the time being. But I would not just stop there. I would definitely, if you contact those interested pharmaceutical companies and see who will buy it.
Just brainstorming, should we stratify patients into like minimal symptomatic, asymptomatic, heavily symptomatic?
Yeah, I think this all sounds like really, really important work to be done. My question is whether a placebo-controlled trial will be acceptable to people with siderosis if, say, they've had any definitive treatment such as a dural repair. Obviously that will be done as standard care, because it would be unethical perhaps not to offer that, but because it's so obviously related to the pathophysiology. But would people find it acceptable to do a placebo-controlled trial? Because I think that's the only way you're really going to learn about efficacy. You can do monitoring studies, but if you don't have a control group, you'll never know. And I do wonder, is it even too late now to do a trial that will tell us whether deferriprone actually works, because it's become so embedded in practice? But this is such a fundamental question of whether deferriprone can be compared with placebo, or whether it's considered standard of care and you test other things against deferriprone. This is just a fundamental question.
Maybe we can poll, would it be unethical to withhold deferriprone if you're in this trial? Do you feel like if we follow you for a year or two and we see some damage, was that an unethical thing to do, to randomize you to a placebo arm and withhold deferriprone?
Well, I don't think so, because there's risk with the treatment, right? So
not only this, you don't have to get to that decision. For people that are intolerant, they can drop off and you can collect them as a cohort on the side that is not taking deferriprone. Or for people that don't want to take into deferriprone, that decide not to, you can collect them all in a cohort and follow them on the side as a cohort, and then just do case matched.
Maybe they're all, they don't want to take it.
Well, then that's why you have to have a matched cohort.
Just to say, what's often done in this kind of scenario is you do a randomized controlled trial against placebo, but you also have a registry kind of embedded in the study where people who say, I really want to take the drug, I don't find it acceptable to be randomized to control. But the difficulty then is you're going to have a bias. So the people who maybe would accept a placebo might be the ones that are less severe in some way, or
Maybe we should do a mild disease versus mild disease. Some people will elect not to be on deferriprone.
would in your randomized trial, the placebo group still need weekly blood draws?
yeah, you wouldn't be able to make it fully blinded probably. But I think the answer is no. You wouldn't be doing weekly blood tests on the control group, would you?
It's blinded.
Yeah.
It's not going to be blinded.
But
You could do monthly when you're licensed.
I mean, if you've got an objective measure like cerebellar volume, maybe blinding isn't quite so important if it's blinded endpoint, but this is all important question, isn't it, for a trial design?
Can I just ask the group what people feel like here. Is it unethical if you want to be on like you don't necessarily want to be on deferriprone? You come to the clinic, you get this diagnosis, you're told there's a trial that you could be randomized to with a 50% chance of not getting the drug. Is that horrific? Yeah. Would not be that way. Funny that Tom asked me if I wanted to it's having the and so I said to Tom that doesn't policy on that, and he just
I was just going to say, in terms of the weekly bloods, if you took other biomarkers, blood biomarkers, then that could be a viable option for the healthy controls.
Regarding the ethics of it, isn't that the purpose of the informed consent? That, you know, you have this informed consent form, you present it to the patient, they can take it home, they can read it, they can think about it, and then they're being informed that they may get the placebo, and they can always opt out and say, no, I don't want to do the trial.
I mean, ultimately, absolutely right. People have the choice whether they want to participate in the trial. That always has to be the ethical basis, doesn't it? What I would say, though, is a long history in medicine of things getting adopted as part of standard care, and no one's ever done a trial to prove whether they work or not. So we still don't know whether some things work. And if you don't do a trial, you will never know whether deferriprone is really effective, because we don't have the level of evidence that proves beyond reasonable doubt that it is effective. But I can see if you're a person with the disease, it's, you know, you may say, I just want to take anything that might help, even if it's unproven. So we have to obviously with people with the condition.
Or the other option would be a new drug versus the best standard of care, which might include deferriprone too. Then that would add two variables. Yes, two variables.
Hey, Michael, you've had more experience than anyone else of monitoring people on deferriprone, so your view is really crucial here.
Yeah, I feel like if there were a good chance that people with superficial siderosis would not progress, then maybe some people would decline. But by the time they come to my clinic, they've gotten worse and their hearing is declining, and now they want some sort of treatment. They don't really want to wait for something. I don't get them when they just have an MRI and they have no symptoms. We get, how many of those do we get? Maybe a handful a year, very few. Yeah, and maybe those people would not really want deferriprone. Everybody else wants something to try to help.
Even if it's unproven.
Yeah,
but that's the problem with this, is when you determine at what stage you're going to intervene, that probably might solve your issue. Because if everyone's coming to you and desperate for treatment because now they're symptomatic, significantly symptomatic, then everyone wants something at that point in time to be done. But it depends on where are you drawing, where are we going to intervene? Is it going to be early on, minor symptoms, auditory symptoms, and whether somebody would like to wait or somebody go ahead and start deferriprone? So it depends on where you are. The more, and not only this, the more you are injured by the condition, probably the less you're going to get benefit from the drug. So you have to play it very well and pick the right balanced approach and when you are going to intervene.
I'm just going to add, it's not you would randomize people to nothing. We've heard from Reese about how supportive care and physiotherapy can be incredibly beneficial. And my personal view is in people who've got substantial disability, probably that's more important than taking a drug, actually. I think that's absolutely vital. And ultimately, people will decide if they want to take part in a trial, I guess, and that's the only way you'll find out.
Yeah, thank you. I'm not sure whether this was already mentioned, but your question about ethics, I mean, if they are, in a certain part of the world where deferoprone is not accessible, so potentially putting them on this clinical trial will give them at least a 1% chance of getting this medication. So I think, with the informed consent, is it necessarily unethical? Because if you're giving them hope, or like another type of drug, I think that's better than nothing.
In a regulatory framework in the UK, for example, it's not a. So we've been battling for years with our medicines committee to allow us to continue to prescribe the drug. In many areas of the UK, it's actually not available because the individual trusts don't agree to prescribe them.
Yeah. Well, and I think, like you mentioned, like other countries, like you said yesterday, like Turkey and Egypt, they may have like, deferoprone, but like, you wouldn't necessarily get the medication from there. So, I mean, there's lots of countries, who may have people with superficial siderosis that do not have access to this drug.
But again, sorry.
Yeah. Is it possible to do this sort of study using mouse models?
No, we need mouse doesn't translate very well to human beings. But the other thing is you can do a crossover design where people start with medication versus no medication, and then later on, if there's any symptoms that are worsening, they can cross over.
To go back to the willingness of candidates, how long would these trials typically run? Because we spoke yesterday about it takes many years before you see the effect of deferoprone. So if you're looking at a long run trial, and then maybe you become a suitable candidate following the trial, it would be even more. So it'd be about how long it would take.
We had discussed running 1 year of double blind and then going 2 years of open label, 3 years total.
The effect of the intervention, even within a year, potentially, but then you have to convince the regulators that this biomarker is a valid measure of the disease and it is going to translate into benefit ultimately. But I think you're right. It wouldn't, people are not going to find it acceptable to say, I'm going to have to wait 6 years before I know whether this drug is something that I might get. But maybe a year, people would say, well, and we'll be learning about the disease. We'll be learning whether it works.
I just want to add to the question, using other countries, that may be something suitable. The only problem that I see with that coming from a third world country is that sometimes the health systems are not very well developed. So doing the follow with the CSF, the LPs, the bloods and the MRIs will be challenging. So I think country more like the UK will be kind of the ideal scenario.
I'm going to ask the neurologists, my colleagues here, about what do they think in their experience, because I completely agree with you, Dr. W. When we're sitting over there the first night, we were talking about surrogates of outcome. So for you that are taking care of siderosis, superficial siderosis, infradentorial, what do you think is the early sign of the disease response? Is it something that you can detect? Is it something that can translate later on instead of sitting for years waiting for an outcome? Is it quality of life?
CSF parent.
After you, Natalia.
I think the first port of call is we'll look for, MRI resolution of the leak if they had surgery, and we're looking for biochemical evidence of resolution on CSF. Clinically, I think what we're looking for is stability of patient symptoms. I personally can't remember, or it doesn't ring a bell with me, where patients say, actually, I'm better. From my side,
Got better.
Yeah, they got better after treatment with the ferripron. I mean, I don't see patients really with the ferripron. I would have seen very few. But reviewing the data, I think what we document is if they're stable or not, or if they're continuing to deteriorate, or new concerns. So, do you have any new concerns about your balance? So, how often usually we see them about once a year, isn't it, David? We follow them up.
Yeah, I mean, you need an outcome that is reproducible and has all the features of a valid biomarker, be that clinical or imaging, don't you?
Yeah, which we don't have.
So we don't have a clinical rating scale for this condition that is validated, that is feasible, that has been tested. I personally think surrogate markers probably.
Yeah, and we were just talking, sorry, David, I'm cutting across. We were just talking at the last night, didn't we, about this clinical measures, the clinical outcome measure that Rory has been working on. So to get the scoring system. So we will need to get that validated, didn't we? Yeah.
I mean, as a general rule, the
is approved by the FDA definition of stable disease is we have a scan that has not changed and then a scan within 6 to 8 weeks that has not changed. So that's what we call stable disease. So we need to figure out what do we call stable disease in this type of disease.
Scoring on actual mobility, hearing. We were using the scoring on the hearing test. We were actually trying to come up with ways that were definitive numbers that could be tracked. You know, on, do you have less than a 5% increase? I'd have to look at the paper again to read exactly what we came up with, but we were going to track it by, did your mobility decrease? And this is by like the up and go, things that can be measured distance wise.
That's a smart.
It affects multiple compartments. And the FDA allowed the SWOT score to be used where it's talking about skin, talking about blood, talking about other areas, and that comes to a score. So that's a wonderful thing to do as functional. Maybe Dr. W might add the CNS ferritin, who knows? But that's a good thing to start with, having a combination, a multi-aspect measurement to say the global response is this, or stable, or improved, or decreased, or worse, something like that. I totally agree with that. A rating scale that captures important features of the disease, which is quantitative. The first thing you need to establish, though, is it sensitive to change over time in a way in which it would allow you to do a trial that's adequately powered to know if there's a difference between the arms, for example. So I'm just wondering if you almost need to be collecting natural history data as part of the trial. Anyway, yeah. And just the biological markers like the imaging and the CSF, they tend to need smaller samples to detect change. So it's what you choose as your primary outcome for the trial, whether it be volume or some biomarker, or whether it's a clinical instrument like you're describing.
But going to your point, I think certainly looking at difference in the audiometry will be important, but also in gait, there are things that you can measure. You can measure the watt base, you can measure the stride with different and how they are stepping. So those things are things that you can measure over time, and you can see if there is an improvement in even the speed of how the patient is walking and those things.
Considered improvement. We were just considering slowing and getting worse. We just wanted them to maintain an even level. If you can spend 4 or 5 years at the same level of disability, that's almost a win.
With PTA, pure tonal this you cannot reverse it, unfortunately. So you just have to maintain it as an outcome.
Measure how the patient is doing with the gait, in the distance, the speed.
The scoring systems.
Certainly, the systems are made to be able to compensate. So if you don't have any further damage, then of course the system is going to be able to compensate, and you might see some improvement that you can measure.
Yes, and also that can improve. I'm being devil's advocate here. I can improve with physio. So, but there are scoring systems,
I was just going to ask you about the HUI3, the quality of life scale, which does encompass all the domains of function, doesn't it? Mobility and hearing and things that we're interested in. Has that been used in any randomized trials of other conditions in hearing?
I haven't looked at that paper for so long. I would have to revisit the literature. It doesn't ring a bell.
It's whether we need to invent another rating scale or whether there's one where all the groundwork's been done already, actually.
Well, you see, there are other patient outcome measures for other diseases. You know more than me, David, but we don't have a siderosis-specific patient-reported outcome measure. And what we have available of the quality of life, and this is the one that comes closest to reflect the impact of the disease on overall functioning and quality of life, because it has these key domains. I mean, HUI3 also has the other part, HUI2, and it's more related to other parts like obstetrics, gynecology, and other bits as well. That's much less relevant to superficial siderosis. So we only used HUI3.
But this measure from gait has been used widely previously, for example, for strokes and those things, to see what is the impact of the physical therapy in the patients getting better with rehab.
It's just some people don't actually have gait problems. They only have.
Yes, and sorry, David. Yes, and others would be so immobile. They would be again hitting the floor with the scoring. So, But in fact, I have some data that I ought to write up by the end of the year again, which we have. I'm sitting on so much data, seriously. So yes, that we will have a small cohort of patients who would have had physio with these outcome measures. So I ought to get it out. So we will be looking at that as well. David's laughing. So
I'd like to wrap up by making just one more call about something we all talked about, is that when we go back to our day jobs on Monday, we're all going to be super busy seeing patients and doing other things. And if we had the manpower in the form of a dedicated clinical fellow or something like that could go back and forth between the UK and the US, who could really spearhead this effort, carry the majority of the workload, that would be amazing, because we all have our limited bandwidth. There's no easy way to do this, and we really just need a physical human being to do this kind of work. So it's a call to the community to help support a fellow. I think we have access to great people, not just from Harvard and UCL, but from everywhere. Anyone who wants to work on this kind of project, we would certainly consider that.
Yeah, just to add, that would have my full support from UCL. We've got a program of visiting fellowships. It would be pretty straightforward to organise a partnership with the US. So I think that's an excellent idea.
Cost estimate, I can tell you at Mass General, it's about $150,000 a year. The way that's broken down is about $95,000 a year salary. There's a fringe benefit, insurance, health insurance, things like that. And then, of course, Harvard and MGH take their tax. So about $150,000 a year.
What about, we don't offer this at Cedars, but what about a sabbatical? Do you guys have that? Or do you have that at MGH?
Yeah, I had a sabbatical a couple of years ago. Which didn't last very long, but
we did a similar project for a grading scale for disability for CSF patients, and it was with the University of Alberta, and their headache doctor spent 2 months with us to validate this scoring scale for disability for CSF patients, and it was part of her sabbatical.
or an exchange program even, or a sabbatical. I think these are great ideas.
You're allowed. Absolutely welcome. All right. It looks like Alex is being paged to the house. David, did you want?
I don't know if we're approaching a close, Mike.
We are.
I've just
Do you
got a
wanna
couple
add
of
something?
points to add, if I may, if that's all right.
Please.
So the first one is we've heard lots of great information at this workshop. I think it's been very educational for me, hopefully the other attendees as well. Whether there is scope to kind of get some kind of output that we might pitch to a journal to really try and get the profile up, a high profile journal, to say this is an important condition that's been neglected, might not be quite as rare as we think. It's got a big burden and impact on the people who have the condition, and we could come up with some kind of roadmap for what we think might be some ways forward that we've just discussed. That was the first thing. And the second one was, I think the point of increasing equity of access to care for siderosis is really important, as well as all the science. And I don't know what power we have to do that, but some kind of manifesto for what everyone with siderosis deserves to have access to would also be part of that roadmap, perhaps, as well as the research. Over.
All right. Call to action. We have a lot of work to do. I just want to thank the research group here for all of the thoughts and ideas, and for the greater group here for all of their input as well. And we'll be putting this together as into a summary, and we can decide how we want to try to publish this, whether we add some data from incidence data or something like that, or just a roadmap, or however we want to do this. But that'll be coming up, and we'll have periodic meetings to try to get this done.
Can I add?
Yeah, please, one more thing.
Because I'm getting the impression that some people misunderstood what I said in my presentation. Is I don't want you to think of FE3 as inert. It is not. Even when it's in hemosiderosis, it is less reactive. Doesn't mean it's completely inert, because it can actually go through something. I don't know which one of you is chemistry here. Can go to something called Fenton-like reaction chemistry that transfers back to Fe2 and gets more damage to the. Because I'm hearing a lot of people talking to me about Fe3 being inert. It's not inert. It is less reactive.
Kyle, anything else to add? So I just want to thank everyone again. I really appreciate all your time and your efforts. Thank you again.
Thank you.